So welcome everyone to the third session, the Comprehensive Neuroanatomy Educational Course presented by the Yemeni Neurosurgical Society in collaboration with the WFNS-YNS Neurosurgical Forum and Neurosurgery Coach and Pakistan Society of Neurosurgeons and the Neurosurgical TV. We are just waiting for Professor Dr. Mujahid Masar, head of Yemeni Medical Council and the president of the Yemeni Neurosurgical Society, to attend and to be moderator of this session. Where today we have two distinguished speakers. First, we will have Dr. Aysu Kabakci that will talk about the anatomy of the parietal lobe, society gyri, and functional areas. And then we will have Dr. Ismail Mansour who will talk about the embryological development of the brain.
You are welcome, Dr. Aysu Kabakci.
Thank you.
And we can start.
All right.
Great, thanks.
Thank you.
For the parietal lobe, sulci, and gyri, and functional areas.
So good evening.
Thank you, Dr. You can start.
Thank you. Good evening again. First and foremost, I'd like to extend my sincere gratitude to the Yemeni Neurosurgical Society and Neurosurgical TV for giving me this opportunity. And today I'm going to talk some about the parietal lobe. So I will sequentially discuss the boundaries, sulci, gyri of parietal lobe for both lateral and medial surface of the parietal lobe. And I will summarize the functional areas within the parietal lobe, and lastly and briefly, I mention the blood supply of the parietal lobe. If we look at the etymology, in Latin, paries means wall, so the parietal bones constitute the wall of the brain. Like the other lobes, the parietal lobe is named after the bone that covers it. And firstly, I'd like to mention the Professor Yaşargil's surgical concept, and there are 7 lobes according to Professor Yaşargil. And here we see that postcentral gyrus is a part of central lobe and not involved in parietal lobe according to this concept. So on the lateral surface, the parietal lobe only have the superior and inferior parietal lobule. However, in the remaining slides, I'm going to accept postcentral gyrus as a component of the parietal lobe for better orientation. So the parietal lobe will be comprised of the postcentral gyrus, superior parietal lobule, inferior parietal lobule, and the perineus medially. Indeed, the anatomy of parietal lobe is much more complex than this, so I want to tell more about boundaries of parietal lobe by using one of our laboratory's 3D model. This is from Yeditepe University Neurosurgery Laboratory, and you can reach this model by scanning this QR code. So first of all, we have the central sulcus as an anterior boundary of the parietal lobe. Then we'll have the postcentral gyrus just posterior to it. And then we have a very prominent sulcus located here, intraparietal sulcus, separating the superior parietal lobule from the inferior parietal lobule. And here we see posteriorly located parieto-occipital sulcus as a posterior boundary of the parietal lobe. And on the superlateral surface, as a summary, each parietal lobe lies posteriorly to each central sulcus, and posteriorly it is delineated by an imaginary line running from the point from which the parieto-occipital notch to the perioccipital notch, which is located approximately 5 cm anterior to the occipital pole. And its inferior boundary is the posterior ramus of the sylvian fissure and its imaginary posterior prolongation. So the lateral aspect is divided into 3 by postcentral sulcus and the intraparietal sulcus. And postcentral gyrus just lies between these central sulcus and the postcentral sulcus. While the intraparietal sulcus clearly delineates superiorly the superior parietal lobule, which is continuous medially with the perineus, and inferiorly the parietal lobule. Postcentral gyrus just lies posteriorly and connected to precentral gyrus along with its superior and inferior extremities of the central sulcus. And it constitutes the posterior aspects of the paracentral lobule and the subcentral gyrus. And the postcentral gyrus is usually narrower than the precentral gyrus, and morphologically, both of them are distinctively obliquely disposed on the superlateral surface of the brain, just superiorly to the sylvian fissure. And their mid portions correspond approximately to the center of each cerebral hemisphere. And as a result of being oblique, superior portions related to the ventricular atrium, while inferior portions are related with the body of the lateral ventricle and just superior to the insula. And the portion of the subcentral gyrus that corresponds to the base of the postcentral gyrus consistently lies over the transverse gyrus of Heschel. And the postcentral sulcus delineates the postcentral gyrus posteriorly, and it's frequently interrupted due to connections between this gyrus and the posteriorly adjacent superior parietal lobule and the inferior parietal lobules. The inferior segment of the postcentral sulcus always ends inside a basal connection between the postcentral and the supramarginal gyri. When we come to the intraparietal sulcus, we are looking from lateral, but we are also looking from a posteriorly and superiorly. And here we see the intraparietal sulcus delineated by yellow dots. And this sulcus lies predominantly longitudinally and slightly ventrally concave along the mid portion. And we know that also intraparietal sulcus has lots of variation. It originates from around the midpoint of the postcentral sulcus, and it anteriorly usually continues with the inferior portion of the postcentral sulcus. And in general, the intraparietal sulcus runs almost parallel to the interhemispheric fissure. And posteriorly, it penetrates into the occipital lobe, and it continues as intraoccipital sulcus, or so-called transverse occipital sulcus. And here we see the depth of the intraparietal sulcus. As the postcentral sulcus, we know that there is lots of interdigitating sulcal branches, and also we have inferiorly and superiorly oriented vertical small branches. An inferiorly oriented vertical sulcal branch will be our intermediate sulcus of Jensen, which separates inferior parietal lobule into two. And then we have the transverse parietal sulcus of Briseau, which superiorly oriented sulcal branch, and it's just divides the superior parietal lobule. So the superior parietal lobule is also a complex lobule lying between the intraparietal sulcus and the interhemispheric fissure, and it's anteriorly delineated by the superior aspect of postcentral sulcus. And it also has a quadrangular shape like pericuneus, and it's continuous with the pericuneus on the mesial surface. And its complex appearance is caused by a folding of the gyrus forming the two U-turns, and that can be called the anterior and posterior parts. It connects anteriorly with the postcentral gyrus and superiorly with the pericuneus. And posteriorly, it continues to the superior occipital gyrus via prominent parieto-occipital arcus that surrounds the parieto-occipital incisure. And occasionally, there is also a small sulcus emerging from the interhemispheric fissure over the superior parietal lobule. It locates just between the postcentral sulcus and the parieto-occipital sulcus, and this sulcus can be called as the superior parietal sulcus. When we come to the inferior parietal lobule, it is divided into two parts by the intermediate sulcus of Jensen, and they can be called the anterior lobule, called as like inferior lobule or supramarginal gyrus, or the circumflex gyrus. And posteriorly, we have angular gyrus, or so-called middle lobule. And their irregular shape is formed by the terminations of three large sulci: the intraparietal sulcus, as we see here, the sylvian sulcus, and the superior temporal sulcus. The bulge of supramarginal and of the angular gyri is responsible for the what we called is parietal tuberosity or parietal bossa. And the supramarginal lobule actually encircles the end of the posterior ramus of the sylvian fissure, and its suprasylvian limb is continuous with the postcentral gyrus, while its infrasylvian limb is continuous with the superior temporal gyrus. And posteriorly and occasionally it rounds the inferior extremity of the intermediate sulcus, which connects it to the angular gyrus. When we come to the angular gyrus, it lies just posterior to the inferior lobule and covers the incursion of the superior temporal sulcus into this region. And the most superior distal branch of the superior temporal sulcus has an ascending course and can either penetrate the supramarginal gyrus or coincidentally can be connected with the intermediate sulcus of Jensen, and sometimes intermediate sulcus of Jensen can be a branch of superior temporal sulcus as well. And posteriorly, the inferior parietal lobule merges with the occipital lobe, and its most inferior portion then becomes always anteriorly continuous with the middle temporal gyrus. And this is the medial surface of the cerebrum. Here we have a parietal lobe lying between the central lobe and the occipital lobe. And this is our another 3D model from Yeditepe laboratory. Now we are looking from the superior. And here we have the parieto-occipital sulcus and we have the central sulcus. And central sulcus ends into the central lobe. Here we have the paracentral lobule. And then here on the medial surface, we have another prominent sulcus that we called as the cingulate sulcus. And we have here the marginal branch of the cingulate sulcus, which forms the anterior boundary of the pyrrhechinose. And each parietal lobe lies on the medial surface of each cerebral hemisphere, and the pyrrhechinose gyrus just lies posteriorly to the paracentral lobule as a medial extension of superior parietal lobule along this perimedial border of the brain, and together with the medial aspect of the postcentral gyrus corresponds to medial portion of the parietal lobe. The pyrrhechinose also has the quadrangular shape like the superior parietal lobule, and that's why it was also called by Dejeven like the quadrangular lobule of Foville. And it's delineated, as I said, delineated anteriorly, marginal branch of cingulate sulcus. And inferiorly, it's delineated by multiple Y-shaped sulcus segments that constitute the subparietal or suprasplenial sulcus. And the parieto-occipital sulcus that separates the pyrrhechinose from kinose is a deep and wide sulcus when open and constitutes a deep fossa which harbors many sulci and gyri within it. And posterior arm of the pyrrhechinose runs in continuity with the isthmus of the cingulate gyrus. And in a superior direction, the anterior gyrus of the pyrrhechinose is also connected with the postcentral gyrus. And the middle and posterior arms of the pyrrhechinose are connected with the superior parietal lobule along the superomedial border of the hemisphere. When we come to the functional areas of the parietal lobe, of course, we have to take a look at Brodmann map. So we have primary somatosensory area, which is located at the postcentral gyrus and at the whole postcentral gyrus actually, and we have the somatosensory association area, which is called as Brodmann area 5. And then we have Brodmann area 7 located within the superior parietal lobule. And inferior parietal lobule is represented with the Brodmann area 39 and 40. And along with area 22, they are called as Wernicke's area. What about the medial surface of the hemisphere according to Brodmann? So we have again primary somatosensory area, somatosensory association area, and the Brodmann area 7 just located within the pyrrhechinose as like the superior parietal lobule. Von Economy and Koskinas actually define the area of map of human cortex in a more complex way, and they actually divide further the superior parietal lobule into three, like anterior, middle, and posterior portion of the superior parietal lobule. Inferior parietal lobule just resembles to Brodmann, and they also showed this sulcus intermedius of Jensen, which separates the supramarginal gyrus and angular gyrus. Medial surface is similar to Brodmann. And after that, Nivonius defined new mural architectonic area within the parietal lobe. And then they defined 30 different parietal mural architectonic areas. And we know that the myelin content is the most in the primary motor and sensory areas. But interestingly, we have another high myelin content area, which is called as area 87. And it's called as the intraparietal dart cluster. And it's just shaded around the anterior part of the intraparietal sulcus. So during the approaches, we have to be careful about this area. And I also want to mention the nomenclature of the Punxsutawney. Here, differently, he called postcentral sulcus inferior segment, but he defined also ascending segment of the intraparietal sulcus, and also we have here the horizontal segment of intraparietal sulcus, and also they showed that it has three vertical inferior oriented smaller brines, and the first one will be the R sulcus intermedius of Jensen. What about the functions of the parietal lobe? So we have motor functions, sensory functions, language functions, reading functions, calculation functions, and the spatial attention functions within the parietal lobe. When we look closer to the motor functions, it prepares and redirects of movements and movement intentions. And as we know that corticospinal tract will be end at the somatosensory cortex of the postcentral gyrus. And the posterior parietal cortex deals with visuomotor transformations, which converts visual information into motor commands. And inferior parietal lobule works on grasping function. What about the sensor function? So we know that somatosensory information after getting into thalamus and going through the posterior limb of internal capsule, it also ends on the postcentral gyrus via these tracts, which are called the medial lemniscus phenothalamic tract and trigeminothalamic tracts. And then we know that electrophysiological studies show that stimulation of postcentral gyrus leads tingling and numbness sensation on the contralateral side. It's impossible not to mention language when we talk about the parietal lobe. So dominant inferior parietal cortex deals with language comprehension, and their damage will lead to Wernicke's aphasia. And dominant supramarginal gyrus and arcuate fasciculus, if there is a damage, it leads to conduction aphasia. Non-dominant perisylvian parietal cortex deals with prosody of speech, so their damage will be sensory aprosodia of the speech. When we look for the reading, alexia with agraphia results due to dominant angular gyrus damage. And dominant angular gyrus has another function, and it's called as calculation center as well. And also we need to mention the Gertzmann syndrome, and it's caused by damage to the inferior parietal lobule. What are the findings of the Gertzmann syndrome? Agraphia with alexia, disorientation for right and left, finger agnosia, and acalculia. What about the spatial attention function? Non-dominant parietal lobe deals with spatial orientation, which are the area 5 and 7. And their lesions leads to difficulty with spatial orientation to the contralateral side, and as well neglect of half of the body and other objects. And parietal association cortex deals the tasks that require mental manipulation of objects. And I'd like recent publications on the functional areas of parietal lobe and the anatomy of white matter. And as we know that the superior parietal lobule is an important region implicated in a variety of tasks. What are those? Like language processing, writing, working memory, attention, visuospatial, and visuomotor integration. And in this study, the corresponding cerebral networks related to these functions deals with white matter tracts are described in the study. And the connections between the superior parietal lobule found with the other lobules, and it has connections almost with all other lobes like frontal lobe, limbic lobe, temporal lobe, occipital lobe, and the other parts of the parietal lobe as well. And what are those tracts we deal with when we talk about the superior parietal lobule? We have the inferior front occipital fascicle, superior longitudinal fascicle, cingulum fibers, and middle longitudinal fascicles, and extreme capsule, and of course we have the superficial white matter, which is also called as U fibers. And this is another study dealing with the angular gyrus, and in this study they divide the angular gyrus into two parts by their position to the superior temporal sulcus. And they found that the tracts related with the superior angular gyrus and inferior angular gyrus is differ from each other. So they summarize the tracts related with those regions. So arcade fascicle, front occipital fascicle, and the tapetum will be both in the superior and inferior angular gyrus, while we only have superior longitudinal fasciculus and middle longitudinal fasciculus in the superior angular gyrus. So Gertzmann syndrome and spatial hemineglect will be observed in the isolated damage of the superior angular gyrus, while verbal anosmia, quadrantonopia, and visual defects will occur in isolated damage of inferior angular gyrus because they have the anterior commissural fibers and the optic radiation fibers. This is another study about the fiber connections of the supplementary motor area, and they divide supplementary motor area into peri-supplementary motor area and supplementary motor area proper. So they found that their functions are differ from each other. So peri-supplementary motor area mostly deals with somatosensory organization, cognitive and non-motor tasks, while SMA proper deals with activation, control, and generation of movement and somatotopic tasks. Because SMA proper have corticospinal tract, but peri-SMA has no corticospinal tract, and it actually has claustrocortical fibers connecting between the claustrum and the anterior edge of the peri-SMA area. And this is another electrophysiological study about the parietal lobe. So they found that posterior reading network overlaps with the language network. So the inferior parietal lobule, underlying arcuate fasciculus, occipitotemporal visual form area, and underlying inferior longitudinal fasciculus, they work with each other for reading and language network. And then also precuneus functions was not clearly defined, and this study had the aim to define the function of the central precuneus. So they did the study, and their goal was to test the hypothesis that the central precuneus is preferentially involved in as executive function. They made impaired trail making test for 35 patients with focal brain lesions involving the precuneus, and it was clearly concluded that the precuneus area has critical role in executive function. Lastly, I will mention the blood supply of the parietal lobe. So we have three main branches as MCA, ACA, and the PCA. What about the MCA cortical branches? So we have central artery giving supply to the inferior half of the postcentral gyrus, and we have anterior parietal artery supplying the superior part of the postcentral gyrus and the anterior part of the posterior parietal lobule. And we have the posterior parietal artery feeding the posterior part of the posterior parietal lobe and supramarginal gyrus as well. And lastly, we have the angular artery supplying both inferior parietal lobule. When we come to the ACA cortical branches, we have paracentral artery, which supplies the premotor, motor, and somatic sensory areas, and it is represented as the terminal portion of the ACA. And we have pericuneal artery and so-called parietal arteries, which supply the pericuneus area. When we come to the parieto-occipital artery, it's a branch of the posterior cerebral artery, and it frequently shows collateral supply networks to the pericuneus and cuneus via anastomosis with the pericuneal artery, here we see, and the calcarine artery. And when we open the parieto-occipital sulcus, we see that it lies here, and as we said before, it's very wide sulcus actually, and it has a pericuneal branch as well. And those were my references when I was preparing this slideshow. And similar to what Vasily Kandinsky said, the principle only by means of a detailed anatomical study can the surgery of art lead to a comprehensive success also applies to our field. And this is the Yeditepe University Microneurosurgical Laboratory. I just want to show a brief video. So we have photo documentation station, we have workstation. We have 4 microscopes. Here we see Professor Abuzer Güngör, who is the director of the laboratory. This is the 3D model of our laboratory. Thank you for listening.
Thank you very much, Professor Aysu Kabakci, for this nice presentation and thorough information. Dr. Mujahid, any word?
Yeah, Dr. Ahmed. Thank you, Dr. Aysu Kabakci from Ankara Hospital in Turkey for this nice presentation. Discussion later on or now, Dr. Ahmed or Dr. Ismail is ready?
We'll see if there is any questions. I think the presentation was clear and very thorough. So we'll see if any one of the audience have any question for Professor Aysu Kabakci or any comments.
You have questions in chat or not? No, you haven't.
I don't see any question here, but
yeah.
Is there anyone want to have any question or have any comments for a professor? As always in anatomy, there is no much questions, and the presentation was very, very informative and very thorough. So I don't think there is any unclear points.
It was very clear.
Thank you. I can stop sharing if you like.
Okay, thank you very much.